Okay, so good morning everyone. I'm Sean Goltz from Waikato University. I wanted to present Leonie Walker and Jill Clendon. They're both adjunct professors at Victoria University of Wellington Nursing and Midwife Graduate School. And they're going to talk about their research with nurses. And I look forward. Thank you.
Thanks. Okay. Well, kia ora koutou, everyone, and thank you very much for the opportunity to come and talk with you about this piece of research that we've done looking at primary healthcare nurses' views of patient privacy and electronic health records. I'm Jill Clendon, and this is my colleague Leonie Walker. We're both researchers with the New Zealand Nurses Organisation. So I'm also a registered nurse, which is my background, and Leonie's more in the health promotion and research side of things. New Zealand Nurses Organisation is New Zealand's largest professional organisation and union, and we represent around 47,000 members, enrolled nurses, registered nurses, nurse practitioners and other healthcare workers, so a large membership basis out of around 52,000 practicing nurses in this country. We want to start by acknowledging the Privacy Commission for the funding that they've given us to look at this very important area of nursing practice. So I want to give you a little bit of background into the topic firstly. As you'll be aware, there's been many recent developments in health information technology, and its increasing use in all areas. In health, IT's changed and continues to change the way in which care is provided and the way in which multidisciplinary teams communicate. Considerable input has been made at the highest professional levels regarding patient record access, data security, and the privacy safeguards required of these new systems. And that, of course, includes the development of guidelines. So while improved communication and easier access to patient records may be clinically useful, particularly in primary health and integrated care settings, the knowledge and understanding of nurses regarding the issues and practicalities surrounding privacy is largely unknown, and particularly in those community settings. Our initial literature review revealed little relevant or recent research on the topic. There is concern about a lack of detailed understanding of the new health IT systems and safeguards, perceptions of the potential to be involved in breaches of privacy with attendant consequences for employment and professional regulation, and concern regarding patient acceptance of IT-based health records. And these are all significant factors, and yet the degree to which they've been addressed in community health settings in New Zealand isn't clear. Community settings where interfaces between primary, secondary and residential care and between multidisciplinary healthcare teams, including pharmacists, allied health professionals, nurses, doctors, orderlies, everybody really, has great potential to benefit patients and increase efficiency, but also may have the greatest potential for issues of privacy to cause confusion, distress, or even harm. While the overwhelming proportion of healthcare data breaches in the US in 2013, around 85% of them, involved theft and hacking, and not insubstantial 10.5% were accounted for by inappropriate access, loss or improper disposal. In New Zealand, several recent cases brought by the Professional Conduct Committee of the Nursing Council of New Zealand to the Health Practitioners Disciplinary Tribunal describe inappropriate access or viewing by nurses of electronic health records of patients and or colleagues. The nurses involved were found guilty and censured. The Nursing Council is also now considering loss of registration as a consequence of breaching privacy on a case-by-case basis, and in fact released a newsletter briefing last night on this very subject. So the aim for our study was to explore the views, expectations, practice and attitudes of registered nurses and nurse leaders working in communities and primary healthcare settings concerning patient privacy, mobile devices and data storage platforms. We used a mixed method case study approach, including an environmental scan and interviews. And some of the documents that we looked at as part of the environmental scan included codes of ethics, Nursing Council of New Zealand Code of Conduct, the Nurse Executives of New Zealand Telehealth Guidelines, and the New Zealand Nurses Organisation Standards of Practice. We undertook a range of individual, paired and focus group interviews with 22 nurses working in 2 distinct community settings, one rural and one urban. We also interviewed a number of key informants. That included 6 professional nurse advisors, 2 medico-legal advisors, and 6 other nurse leaders and managers, so a fairly broad cross-section. Data were recorded by a tape recorder. We transcribed those and analysed them descriptively, and we had ethics approval from Victoria University to do the study. So talk a little bit about some of the findings, and I'm going to talk about those specifically to do with the privacy side of things, and then Leonie's going to move on to talk about some of the practical implications and findings that came out of the study. So there's almost 2 parts to this. We found it quite interesting anyway. So firstly, our review of the nursing regulations, guidelines, policies and procedures revealed that privacy and confidentiality of patient information are viewed as vitally important. They're cornerstones of nursing practice. So a couple of quotes. I mean, now we have in our employment agreement a fairly hefty discussion about confidentiality and privacy. So it's in people's employment agreements now. So yep, I'm pretty clear on that, which is good. That's my closing comment, you know. Privacy is for everybody. So people had a pretty good understanding of what confidentiality and privacy meant. And there's been significant awareness raising and training regarding it and e-records across all settings. So not just hospital-based, but also in the community as well. One of the things you have to do as one of the things, I think it's annual or biannual mandatory training, is around the Privacy Act. Confidentiality is high on the list, and I've had many conversations with our management. Systems are set up well to keep reminding nurses not to breach privacy and confidentiality, and also maintain those records in a secure way. We'll talk a little bit more about the flags that are in place to actually warn nurses in a moment. There was a consensus that privacy was safer with the use of tablets and phones, as these were in effect a password-protected portal to notes rather than copies of notes themselves. So hopefully the days of notes being left in district nurses' cars between patient visits are over. We hope. Nurses are largely widely aware that within DHBs especially, every access of notes, either paper or electronic, is auditable, and that flags could be generated and consequences ensue following inappropriate access. Privacy breaches are spotted, they're investigated, and historically this has led to a severe warning. And of course the cases that I spoke about earlier from the Nursing Council of New Zealand are now being investigated at the highest level with quite severe consequences for nurses' registration. Direct electronic communication with patients, so texting to remind people of appointments or being able to get straight through to them rather than risk leaving messages on answer phones, or home answer phones in particular, is helpful for both privacy and immediacy. There are some risks. Nurses in the rural case study face a number of professional boundary issues, particularly when they know an entire family, both personally and professionally. In small communities, though, interprofessional communication can be easier as people have known and worked together for many years. Voices can be recognised. You can pick up the phone and go, oh yeah, I know who that is. But on the other hand, privacy can be harder to maintain in small rural communities. And some of the nurses we spoke to had chosen to seek healthcare for themselves in other areas due to concerns about their own personal privacy. Questions were also raised about whether patients fully understood and consented to the use of their notes for competency or disciplinary processes, or for teaching or audit. It was reported that some nurses revisited the notes of patients they'd previously cared for in order to document their own professional practice. And this was one of the areas that we identified that better understanding of the issues involving privacy and confidentiality was required, and we'll talk about how we've addressed that later on as well. Some were also unsure about the legitimacy of accessing their own notes, and this generated some quite interesting conversation. All nurses that we spoke to were very aware of the processes around patients accessing their own notes, and most were aware of, although not all understood or agreed with, policies relating to looking up their own notes in the system. So some grey areas there. So I'm going to hand over to Leonie, who is going to talk through some of the practical issues that we found and the consequences for those in terms of privacy.
Just before you do,
Yeah.
In the spirit of consent and full information, I thought I should belatedly let you know that you're being live streamed to the entire universe. And I wasn't sure whether my team had checked that out, but just be aware, speakers, if you'd prefer not to be able to be watched over breakfast in Kazakhstan, let Sam know.
Is that the question as well, John, or is it just the presentation?
It's just the presentation, not the question.
No pressure. Thank you. Yeah, just talk about some of the practical issues, and this comes back a little bit to some issues raised in the previous speech. The first one I'll talk about is cell coverage and topography. Obviously this related most to the rural and extremely remote and wild and rugged sections that we were in. And cell phone coverage, and therefore smartphone coverage, and even broadband access at the base, or electricity at the base in some cases, were subject to outages. And nurses, being the sort of creatures of invention and resourcefulness that they are, they occasionally manage some really creative workarounds that may not have been anticipated by the system's designers. So rather than being able to access the details of the patients that you're visiting around the day, they would print out notes and stick them in their diaries so that they had those details with them in case the cell phone coverage dropped out. The major practical issue that was identified, though, was the one about logins. Now, I'm sure all of you, as I do, have multiple logins for goodness knows what applications and banking and who knows what. But within the health settings, nurses too have multiple logins to different systems, to records, to clinical decision-making algorithms. And these change regularly. Some of them are on a timed basis, some of them are prompted by systems changes. Now, this was a quote which exemplified the frustrations of this. You have to remember them. Then you have another one which expires, and then it rolls over after 90 days, and I'm not sure the number of times, and different ones to log into MedTech, which is useful, and at least it stays the same, but I can't ever remember it, so I don't use it. And even where they find MedTech useful, if you can't log into it, you can't use it. But my particular favourite quote was, "We have to change them all the time." Yeah, and I've only ever had so many differently named pets. And all of these were indicative of conditions that were absolutely ripe for inappropriate password sharing. Now, banks, Child, Youth and Family, I believe, probation, have managed fancy technical solutions, little chips, electronically random number generated things that mean that you don't actually have to remember all of these passwords to all of these things. So it was very helpful to be able to stand up in front of the Health Information New Zealand tech boys and say, make it so. The practical issues and devices, apart from the ones about the electricity going down or the broadband going down, the average age of our nurses is now creeping up towards 50. Some of them have issues with sight of tiny text, with little tiny keyboards, and Although in some cases there was evidence of the devices that they were expected to use being trialled in the field, there were also people that said, yeah, we might have tried them, we said they didn't work, we said we couldn't use them, but they rolled them out anyway. And a particular issue that some of the clinicians in the audience might recognise, I didn't know that district nurses' favourite thing to do is to take photos of wounds as they heal, so that you can track the shrinking margins and peeling scabs and such like. And that's something they really need to be able to do. They used to be able to do that perhaps on a cell phone. They now can't do that because their IT systems really freaked out about people uploading photos into systems, both for data security and for the possibility of introducing worms and viruses and things. So people would sometimes use their personal cell phone, take a photo, take it back to base, get the admin person to somehow load it into a colour photocopier, print it out onto paper and put it in some notes somewhere, which loses the clinical capacity to directly compare, to zoom in on particularly crunchy, juicy areas and such like. So you're losing some of the clinical ability to use these things. And that, again, may not have been anticipated by the systems designers. The practical issues, IT support. I doubt there's a person in this room who doesn't value good IT support at work when they get it. So I'm just nodding to my colleague. When asked what sort of IT support do you get for the introduction of all these new systems and ways of working and the ways they approach, the answer given was, well, it's very overloaded. So a follow-up question of overloaded but effective? The answer was, I wouldn't say it was effective. So there were such frustrations. People know these days that internet-connected smartphones have apps, they have decision-making tools, they have fantastic things that they could both use themselves in terms of helping their patients particularly manage long-term conditions, or use themselves to just make absolutely sure that they are giving the most up-to-date and modern advice. And yet, the practicalities of the system and the costs of data meant that nurses in the field were often prevented from having phones that could actually download data that might cost money, which is very frustrating when you feel there are tools that people have put a lot of effort into developing and you're just not able to use them. And another issue which we hadn't thought about, but was a question that was raised, was whether the IT support people themselves had enough information about the privacy implications of health-related data. Often they're jumping onto screens to help you unfreeze or unstick or whatever IT people do. And yes, they all sign confidentiality agreements. Of course they do, everyone does. But they are maybe less prepared than the clinicians to understand the health and social impacts of recognising people's names, wondering about diagnoses, prognoses as they pop up on their screens. Another project, perhaps. Another practical issue was about read-write access. Now, again, some of this was about practicalities, but many of the nurses out in the field found that while they could read the access to say, who am I supposed to be visiting and what was going on for them last time someone logged into the system, that they were actually unable to write directly in the field onto these notes. So the days when a district nurse might write up her patient visit in the car between patients whilst it's all fresh in her mind, and then pop the file back into the system when she returned to base so the next user could immediately access the updated clinical notes, were often not so. And after a long day on the road, being held up by weather or slips or whatever, there were some concerns that there might be delays in reporting and updating the clinical fields. And linked to that is the differential access that multidisciplinary teams, particularly in the community, now have. They used to be able to share paper notes. The social workers, the allied health professionals, sometimes the caregivers need to know this stuff, the pharmacists. But now that these systems were sometimes separated out, particularly the allied health professionals and social workers were finding that they couldn't access multidisciplinary notes in the same way. And this too, we feel, perhaps due to concerns about privacy, was limiting the clinical applicability of the systems. The interoperability between applications was a big concern, and I suppose we're going back here to things like the medtech, the wound things. Even radiology, we had an instance in a hospital where an x-ray of a patient's skull following coming off a bike or something was printed out, put in a trolley, trundled down a corridor, and might or might not turn up at the right place at the right time for somebody to be able to make a decision. 2016. So sometimes the practicalities and sometimes the concerns about privacy are interfering with the clinical requirements at the coalface, and that was fairly similar to the last one. So the practical problems driving actual privacy risks. I think the biggest one is these workarounds, these innovative ways that you find to make something work for you because you need it. So the printing out of labels. Jill mentioned earlier, nurses have been asked to justify their access to patient records. Now this is because these days nurses are often moved around. So, oh, they're short on ward 6, get yourself up to ward 9, we're desperately short in neonates. But someone in the big system says, hang on a minute, you're not down on the list as looking after Mrs. So-and-so. What are you doing? You weren't even supposed to be on the ward. So having to go back and being able to justify that actually, yes, I was on that ward and I was looking after Mrs. So-and-so. But it does engender a lot of anxiety for people who are asked to deal with that. And logins and temporary logins. In the rural areas in particular, a lot of locums, short notice. How do the IT system know how to give the locums in particular access to the right things? So there was some examples of sharing of logins, also with student nurses who again signed confidentiality agreements and are supervised in their access to notes. But some of the practicalities of the requirements of teachings or locums or temporary staff perhaps haven't been thought of. And another issue that we found that, again, maybe hadn't been thought about was where nurses were preparing documents, for example, discharge summaries. And you need to think about things. You might write a draft, you want to think about it, you want to consult your own notes and go back and write it up better before the final version goes out. In this case, there was no system by which those temporary drafts could be stored, so they were being stored on flash drives and hard disks in a way that again may not have been thought about and was certainly not ideal for security. So in conclusion, like the previous speaker perhaps, we found nurses do have a good knowledge of the levels of patient privacy that is required. Definitely need to do some more work about them accessing their own notes. We certainly need to do some more work, I think, with patients and their understanding of shared records and who gets to know and why. The nurses asked about that did have comments like, well, patients assume that we share these things. They don't want to have to tell their story 16 different times to 16 different clinicians. Or why are you not sharing them? It's supposed to be IT these days. But there were also other concerns from nurses now that patients can access their notes, that they perhaps write them in ways that are different from the ways that they used to write them before they knew that patients would access their own notes. Now that may or may not be a very good thing. And we had a plea to the wonderfully smart techie people who design these things to continue to ask the end users of their fantastic systems what they actually need and how they work before they proceed. Training must be ongoing, that's a given. We believe that the health IT systems must support privacy and confidentiality, of course they will, but we also don't want them to create barriers, and the delayed logins, multiple passwords, and the infrastructure must be designed with the end user in mind, not to have the nurses change their practice to fit what the IT people can do. And nurses in rural settings definitely need greater support and some practical things to help them manage this better. The outcomes for the project, we do have the report to the Office of the Privacy Commissioner, which is available on the New Zealand Nurses Organisation website. That's available for download. We got an article into the Journal of Telemedicine and Telecare, which was the beat up of the tech people to involve nurses more. That went down very popularly. 2 new NZNO guideline documents have been developed. I will hand over to Jill to describe the guidelines one, but we also updated our technology and telehealth position statement with reference to the Nurse Executive New Zealand. And we've done a lot of dissemination of this stuff. So we've talked to the Nurse Executives New Zealand, who are the mainly directors of nursing, people like that. We've also talked to the NNO, the National Nursing Organisation, who are people who involve the educators and the regulators, as well as some of the key people, just to alert them to some of the little niggles that we identified in the project. And the guidelines one is such a specific one that I'll hand back to Jill.
Yeah, this was an interesting one, and it was something that came out of the study where we'd identified that nurses were struggling to understand whether they could access patient notes to write their own professional development case studies and reflections, what the circumstances were in which they could do that or not, and many nurses have been. And so I started to write these guidelines, and it's very complex when we look at the privacy code, the nursing ethics codes, the standards of practice, and pull all these together, the health legislation as well, trying to find a practical way forward which is useful for nurses in terms of their own professional development was challenging. So it took a little while to get these together, but I'm really pleased to have finished them and have disseminated them. And the latest framework on professional development programs for nurses refers specifically to the guidelines, so they're already out there being used at that level for nurses. I've spoken with other nurses who have been referring the nurses that they are working with to the guidelines as well. So already we're starting to get some of that information, that complex information out there, so that nurses know how they can be developing their own professional practice in the context of patient privacy and consent. And there have been some changes from our previous advice as a result of the research. So we're really pleased that that's a practical outcome from this study. Yeah. Thank you.
Thank you.